Welcome to the deep dive, where we take complex topics and distill them into essential, actionable knowledge.
Hmm.
Today, we're plunging into a really foundational yet, let's be honest, often emotionally sensitive aspect of patient care: bowel elimination.
It really is.
We're pulling directly from a key chapter in Fundamentals of Nursing. The one Potter, Perry, Stockert, and Hall, 11th edition. Definitely a must-know for any nursing student ready for your next clinical or exam prep.
It's such a critical area because, subtle changes in bowel function
Yeah,
can be the earliest signs of broader, sometimes pretty serious health issues.
exactly.
Understanding what's normal, and that varies, right?
Sure.
And all the factors that can disrupt it is just vital for providing empathetic and effective care,
Mm.
always respecting privacy and the patient's emotional needs.
Absolutely. So, our mission today is simple: equip you with a clear, concise, and clinically relevant understanding of bowel elimination. We're going from the science behind it all the way to practical nursing interventions. We'll hit key concepts like patient care principles, clinical decision making, safety stuff, all through a real world lens.
Yeah, think of it like connecting the dots, from the textbook theory right to the bedside.
We want you to be not just informed, but well informed.
We'll cover everything: managing common problems like constipation, understanding complex surgical diversions. We'll even walk through some key procedures, always hitting that why behind the what.
Okay, to keep this grounded, let's bring in a patient scenario. Meet Chavela Josefa Rivas Mendez. She's 78, just discharged home after a left knee replacement.
Okay.
She lives in an active, older adult community, but her nurse, Sergio, he's got a priority concern. Chavela has a history: hypertension, osteoarthritis, and frequent constipation.
Right, that's a common mix.
So Sergio's initial assessment, it's focused on her surgical recovery, her ADL's activities of daily living, how she's moving, caring for herself, and crucially, her bowel function, especially since her new pain meds.
The opioids.
Exactly. Could easily make that constipation worse. So we'll keep Chevelle in mind as we go.
Sounds good. A great way to frame it.
Okay, let's unpack the science first, the why behind it all. Before we jump into interventions, what are the essential parts and functions of the GI tract?
Right. So basically the GI tract is, one continuous tube, the alimentary canal, goes from the mouth all the way to the anus with some helper organs like the liver, pancreas, its main jobs, absorbing fluid and nutrients, prepping food for cells, and storing and getting rid of waste.
Okay.
And here's a really critical point for nurses. It absorbs massive amounts of fluid, high volumes, which means fluid and electrolyte balance is always a big concern if GI function gets messed up.
Always. Okay, let's trace that food journey quickly. Starts in the mouth, right? Chewing, saliva.
Yep, mechanical and chemical breakdown. Then down the esophagus to the stomach. Stomach stores it, mixes it into chyme, that thick liquid stuff, and starts digesting protein.
Got it. Then the small intestine, that's where the real absorption happens.
Exactly. Especially the jejunum carbs and proteins, and the ileum for water, fats, vitamins, iron,
Yeah.
digestive enzymes, bile, they all get added there.
Okay.
And here's a key insight for you. If that small intestine isn't working right, maybe inflammation, infection, blockage, even surgery, it massively alters digestion.
Yeah.
You'll see major electrolyte and nutrient deficiencies in your patient. It's a direct link.
That's a really important connection. Okay, and finally the large intestine, the colon.
Right, the primary organ for bowel elimination. Shorter, wider. Its main gig is absorbing lots of water, like up to 1.5 liters a day, plus key electrolytes, sodium chloride.
And the speed matters hugely here, doesn't it?
Totally. Peristalsis speed is everything too fast, watery stool, diarrhea. Too slow, it absorbs too much water back and you get hard stool. Constipation,
Makes sense.
then the rectum, usually empty till right before defecation. Stool moves in, causes distension, triggers that urge. Then sphincters relax, muscles contract, and hopefully out it comes. Should be painless, soft, formed if someone's straining.
Red flag.
Big red flag.
Yeah.
Something's up.
Okay, great overview. So with that basic anatomy and physiology, what are some of those factors, maybe the less obvious ones, that really influence a patient's bowel habits? What should nurses really be watching for?
Yeah, it's rarely just one thing. So many factors affect peristalsis: stool characteristics, take age, infants, super rapid peristalsis, older adults like Chavella, often decreased chewing, slower peristalsis, weaker muscle tone, bam, increased constipation risk.
Right. And diet, it's more than just eat your fiber, isn't it?
Oh yeah, regular food intake gives bulk, helps move things along. But what you eat matters. Fiber's great, but like cabbage or beans, can cause gas, and gas stretches the bowel wall, which can actually increase motility sometimes, but also cause discomfort.
Interesting. And fluid intake, often overlooked.
Hugely underestimated. General goal is about 3.7 liters a day for men, 2.7 for women. But simply put, enough fluid plus fiber equals softer stool. Not enough fluid. Hard, dry stool. Think about Chevella limiting fluids because she's afraid of accidents.
Creates a cycle.
Exactly. And physical activity directly stimulates peristalsis. Immobilized patients like post-op. Things slow right down. That's why we push early ambulation so much. It's not just for circulation or lungs, it's for the bowels too.
Good point. What about the mind-gut connection? Psychological factors?
Oh, they're huge. Stress can speed things up, diarrhea, gas, or slow them down, like constipation and depression. And for people with chronic conditions like IBS or Crohn's, stress is often a major trigger for flare-ups.
Even personal habits, routine, privacy, they matter more than we think.
Absolutely.
Yeah.
Someone used to their own bathroom at a specific time. A busy hospital environment can completely throw off their routine and position. Squatting is actually the ideal physiological position.
Right.
For bedbound patients, just getting the head of the bed up 30, maybe 45 degrees makes a huge difference compared to lying flat.
Simple but effective. Okay, what else?
Yeah.
Pain.
Yeah, if it hurts to go like with hemorrhoids or after rectal surgery, patients will consciously hold it in. Classic setup for constipation. And pregnancy. The fetus pressing on the rectum, plus hormone-slowing peristalsis in the third trimester. Very common cause of constipation and hemorrhoids too.
Right, and then the big ones, surgery and anesthesia.
Major disruptors. General anesthetics cause ileus, basically. Peristalsis stops temporarily, usually 24, maybe 48 hours, if the surgeon actually handled the bowel. That also causes ileus, and inactivity being NPO.
Nothing by mouth.
Right. It all delays getting back to normal. And of course, medications. Opioids are notorious for slowing peristalsis, causing constipation. Antibiotics can wipe out good gut bacteria, leading to diarrhea.
And laxatives. Need to be careful there, right?
Absolutely critical point for your practice. Stimulant laxatives, while they work fast, can cause dependence if used long-term. The bowel kind of forgets how to work on its own. You really want to guide patients toward more sustainable strategies like fiber, fluids, activity.
Okay, that's a lot of influencing factors. Now let's focus on the common problems nurses see when things do go wrong.
Right. These usually stem from those factors we just discussed. First step, constipation. Remember, it's a symptom, not the disease itself. For your patient, it means infrequent stools, like fewer than 3 a week, hard, dry, maybe painful to pass.
And if that doesn't get resolved, impaction.
Exactly. Unrelieved constipation leads to hardened feces stuck in the rectum, sometimes even up into the sigmoid colon. It can actually cause an intestinal obstruction. High risk for patients who are debilitated, confused, or unconscious.
And the sign isn't always no stool, is it?
That's the tricky part. Sometimes you see continuous oozing of liquid stool. It's seeping around the hard mass. Patients might also have no appetite, nausea, vomiting, a distended, crampy abdomen. A digital rectal exam might be needed to confirm it.
Okay. Then the opposite problem, diarrhea.
Yep. Increased number of liquid unformed stools because things are moving too fast through the gut. That rapid transit means less time for water and nutrient absorption, so dehydration is a major risk.
What are the signs of dehydration we need to watch for?
In adults, thirst, urinating less often, or dark urine, dry skin, fatigue, dizziness. In infants and kids, it's even more critical. Look for dry mouth or tongue, no tears when crying, no wet diapers for 3 hours or more, sunken eyes or cheeks. Diarrhea also risks fluid electrolyte imbalances and really bad skin breakdown.
What causes it? You mentioned antibiotics.
Yes, especially leading to C. diff, Clostridium difficile. Super common healthcare-related infection. And remember, for C. diff, alcohol hand rubs don't cut it. You need soap and water to kill the spores.
Crucial point. Other causes.
Food-borne bugs, so hand hygiene and food safety are key. Also, sometimes after lower GI surgery or tests, even things like enteral nutrition, food intolerances like lactose intolerance causing pain, gas, diarrhea after milk, or food allergies like celiac disease with gluten.
Okay. What about flatulence? Just gas.
Well, yeah, it's gas accumulation, but it stretches the bowel wall, causing fullness, pain, cramping. It can be pretty severe if motility is already slow from, say, opioids or recent surgery. And finally, hemorrhoids.
Those dilated veins.
Right, in the rectum. Often from straining, pregnancy, even heart failure. Painful and irritated. So the main nursing goal: soft, painless bowel movements, diet, fluids, exercise again.
Okay. Sometimes surgery is needed, creating bowel diversions. What do nurses need to know?
Right, so this means creating a stoma, a surgical opening, where part of the intestine comes through the abdominal wall. If it's the small intestine, it's an ileostomy, large intestine. colostomy.
And the output is different depending on where it is.
Hugely different. That's key for your assessment. And ileostomy. Expect frequent liquid stool because it hasn't gone through the colon to absorb water. A sigmoid colostomy way down low. Much more formed stool, maybe even manageable with irrigation instead of a pouch sometimes.
Gotcha. And there are different types of these ostomies.
Yeah. A loop colostomy is often temporary, reversible. They bring a loop of bowel out. It often has two openings, one for stool, one for mucus. An end colostomy brings one end out, folds it down like a turtleneck. Can be permanent or reversible. Sometimes the leftover downstream bowel is removed or sewn shut. That's called a Hartmann's pouch.
Okay. Any others?
Less common, but there's the ileoanal pouch anastomosis, or J-pouch, often for ulcerative colitis. They remove the colon, make a pouch from the small intestine connected to the anus, kind of mimics the rectum. And for kids with certain continence issues, there's an antegrade continence enema, ACE procedure, using the appendix to create a port for enemas. Knowing the type helps you anticipate care needs.
Right. This is where we tie it all together, the nursing process. It's our roadmap, right?
Yeah.
Applying knowledge, experience, critical thinking.
Exactly. It's how we make those sound clinical judgments. Starts with assessment and
Yeah.
always begin through the patient's eyes.
Because bowel stuff is embarrassing.
Totally. Patients need nurses who are knowledgeable, respectful of privacy, and understand that culture can play a role in habits, beliefs.
So the nursing history is crucial. What's their usual pattern? Frequency, time of day. A bowel diary, like Sergio might suggest for Shavella, can be super helpful here.
And you need to ask about stool characteristics. The Bristol Stool Form Scale is your friend here. Describe it verbally. Is it like type 1, separate hard lumps, hard to pass, or more like type 4, smooth and soft, like a sausage or snake?
Yeah.
Or type 7, watery, no solid pieces?
Good way to standardize it. What else in the history?
Routines they use. Hot tea, specific foods, laxative use type, frequency, any bowel diversions, appetite changes, diet history, fiber, fluids, past GI surgery or illness, family history, especially GI cancer.
Meds are huge.
Absolutely. Laxatives, antacids, iron, pain meds like Chevella's oxycodone, emotional state stress, exercise habits, any pain or discomfort, where, when, what type, and social history, living situation, bathroom access, mobility issues.
Okay, then the physical assessment. Start with the mouth, check teeth. Gums. Poor dentition affects chewing.
Right. Then the abdomen. Look first, contour, shape, symmetry, any scars, stomas, distension. A tight drum-like belly usually means gas. Then listen, auscultate for bowel sounds. Normal is clicks and gurgles every 5-15 seconds. Absent or hypoactive could be ileus. High-pitched, hyperactive might suggest an obstruction.
Though you mentioned some debate about how useful auscultation is clinically.
Yeah, some studies, especially in ICUs, question its definitive accuracy for decision-making, but it can still offer clues. Then gently palpate for any masses or tenderness. Make sure the patient is relaxed.
What about fecal specimens?
Key things. Proper collection, no urine or water mixed in. Medical asepsis. Good hand hygiene. Timely transport to the lab. For fecal occult blood testing, FOBT, screening for hidden blood.
Important for cancer screening.
Very. Two main types. The guaiac test, GFOBT, needs diet prep. Avoid red meat for 3 days, aspirin SAIDs for 7 days, they can cause false positives, and avoid vitamin citrus for 3 days, false negatives.
Wow, lots to remember.
It is. The fecal immunochemical test, FIT, is more sensitive, fewer restrictions, but costs more. Both usually need samples from 3 separate movements. And any positive FOBT needs a follow-up colonoscopy. Don't forget that.
Okay, and diagnostic exams, like
No.
scopes?
Right. Direct visualization like endoscopy or colonoscopy uses a scope to look inside. Can even take biopsies. Needs bowel prep, sedation. Indirect visualization includes things like X-rays, KUB, CT scans, MRI. Most require bowel prep and being NPO, nothing by mouse beforehand. Your role is often prepping the patient and managing them afterwards.
So let's loop back to Shavella. What were Sergio's key assessment findings again?
Right, so he noted her discomfort rubbing her knee and abdomen, vitals stable, but weight loss, bloating, no BM in 3 days, pain 3, 6, 10, taking oxycodone, tired, forgetting her PT exercises, limiting fluids due to fear of incontinence, liking fresh fruits, veggies. Her typical diet had some fiber, but maybe not enough consistently. Lots of cues there.
Okay, that's a solid assessment. Now, analysis and nursing diagnosis, clustering those cues.
Exactly. Critical thinking time. For Shavella, Sergio likely identified constipation as a major one, related to the opioid, decreased mobility, maybe low intake. The cues: opioid use, lack of produce, low fluids, less movement, bloating, no BM for days.
Makes sense. What else?
Probably impaired mobility related to her knee pain and maybe not fully grasping the exercises, and definitely acute pain from the surgery itself. These diagnoses guide the next steps.
Which is planning and outcomes identification, setting goals with the patient.
Yes, with the patient. It has to be individualized. Factor in their habits, ensure privacy, follow standards like WOCN guidelines. Outcomes need to be realistic, measurable.
So what would success look like for Shavella regarding her constipation?
We want her to, say, establish a regular pattern, be able to list foods and fluids that help soften stool. Start a regular exercise routine, report passing soft, formed stool daily without straining, that kind of thing.
And priorities matter, right? You can't teach diet if pain is uncontrolled.
Absolutely. Maslow's hierarchy, right? Address the most pressing needs first. Pain control might come before in-depth diet teaching. And teamwork. Involve family, dietitians, PT, specialized nurses like WOCNs.
So Sergio's plan for Shavella.
For constipation. Increase fluids to maybe 2,000 ml a day. Boost fiber bran, apples, salads, beans. Aim for soft stool in 24 hours. Work with PT on activity. For mobility, goal maybe walk 5 minutes every hour awake. PT teaches exercises. For pain, goal pain 3 or less. Teach acetaminophen use, try ice. Maybe plan non-drug methods for the next visit.
Okay, plans in place. Now, implementation, putting it into action.
This is where patient-centered care really happens. Empowering patients, educating them on diet, fluids, routine, exercise, how to manage things themselves.
So health promotion is key, reminding people about normal defecation habits.
Definitely. High-fiber diet, enough fluids, taking time usually an hour after a meal is when the gastrocolic reflex is strongest. And positioning. Sitting, squatting if possible, or at least head of bed up 30-45 degrees on a bedpan.
We also have a role in colorectal cancer risk reduction.
Huge role. It's the third most common cancer. Promote exercise, healthy weight, no smoking, high fiber, less red processed meat. And push screening starting at age 45. Whether it's FOBT annually, colonoscopy every 10 years, know the guidelines.
And address disparities.
Critically important. Lower screening rates in some groups, like African Americans, often due to access, cost, fear, distrust. We need to build trust and tailor our education.
Okay, moving to acute care interventions. Helping someone on a bedpan. Seems basic, but there's technique.
There is. Head of bed up 30-45 degrees. Lying flat makes it much harder, causes hyperextension. Ensure privacy, warm the pan if possible, use powder sparingly on the back unless contraindicated, roll them onto it carefully, always hygiene afterwards.
Medications. We touched on laxatives. Any key types to highlight?
Bulk forming, like psyllium or methylcellulose, are generally safest for long-term use. They mimic fiber. Osmotic, like Miralax or Lactulose, pull water in. Stimulants like Bisacodil or Senna irritate the bowel effective short-term, but again, watch for dependence. Suppositories work faster because they're right there.
And enemas. When are they used?
To stimulate defecation, often for constipation or bowel prep. Cleansing enemas aim for complete evacuation. Tap water is hypotonic use cautiously. Risk of water toxicity. Normal saline is safest, isotonic. Hypertonic solutions like Fleet pull fluid in, low volume, but avoid in dehydrated patients or infants. Soap suds are irritants. Use Castile soap cautiously.
How do you give one safely?
Clean technique. Gloves. Explain. Left side lying position is best. Lubricate the tip well. Insert gently toward the umbilicus about 3-4 inches for an adult. Raise the container slowly 12 inches above the anus usually. If they cramp, lower the bag or clamp the tubing briefly. Encourage them to hold it as long as prescribed.
Safety checks.
Check pulse beforehand if they have heart issues, vagal nerve stimulation risk.
Yeah.
And generally limit to 3 consecutive cleansing enemas to avoid fluid electrolyte problems.
What about digital removal for impaction?
Last resort, it's uncomfortable, risks irritation, bleeding, and that vagal stimulation sudden heart rate drop. Use plenty of lubricant, gentle finger insertion, carefully break up and remove small pieces. Monitor pulse and comfort closely.
Okay. NG tubes, nasogastric tubes. Why use them?
Main reasons: decompression, removing stomach contents, gas, preventing distension after surgery. Yeah. Also enteral feeding, compression for bleeding, or lavage, washing out the stomach.
Types.
Fine bore for feeding meds. Large bore, like a Salem sump, for decompression. The Salem tub has 2 lumens, one for drainage and that blue pigtail air vent. Crucial. Never clamp the air vent, hook it to suction, or irrigate it. It prevents the tube sticking to the stomach wall.
Insertion pointers.
Clean technique. It's uncomfortable, warn the patient. High Fowler's position, chin to chest helps. Measure nose, earlobe, xiphoid, NEX. Lube the tip. Advance gently as they swallow sips of water. Watch their O2, satin breathing.
How do you know it's in the right place?
X-ray is the absolute gold standard for initial placement, period. Before that, you can aspirate contents should look gastric, greenish tan, and check pH, should be acidic, 1 to 5, but X-ray confirms it's not in the lung. Secure it well, Check nares for pressure. Keep head of bed up 30–45 degrees always to prevent aspiration. And never reposition after gastric surgery without an order.
Okay, shifting to continuing and restorative care. Ostomy care, big area.
Huge. Patients wear pouch. Empty it when 13 to 12 full. Change the whole system, pouch and wafer every 3–7 days, or if it's leaking. Assess the stoma should be pink or red, moist. Assess the peristomal skin, the skin around the stoma, irritation, rash. Leakage is the enemy here. Stool enzymes break down skin fast.
Skin protection is key.
Vital. A WOCN wound ostomy continence nurse is your expert resource. They're fantastic.
How do you change the pouching system?
Gently remove the old one. Push the skin away from the adhesive. Don't just rip it off. Use adhesive remover if needed. Clean the skin with plain warm water. Pat dry thoroughly. Measure the stoma, especially important in the first 4–6 weeks post-op as it shrinks. Cut the opening in the new wafer just slightly larger than the stoma, maybe 18-inch. Apply the pouch. Press firmly around the stoma. Have the patient hold their hand over it for a minute. Warmth helps the seal.
Nutrition with ostomies. Any special rules?
For colostomies, usually just a healthy balanced diet. For ileostomies, they lose more fluid and salt, so they need to consciously replace it. Drinking 8-ounce water when emptying the pouch is a good tip. Watch out for high-fiber foods that might cause blockage, like popcorn, mushrooms, pineapple too well.
And the psychological side.
Can't overstate it.
Yeah.
Body image changes, self-esteem hits, sexuality concerns. It's a lot. Offer emotional support, connect them with resources, support groups. Difficulty managing the ostomy really impacts self-esteem.
What about bowel training?
Good for chronic constipation or fecal incontinence, especially if there's cognitive impairment. It's about establishing a routine. Try to toilet at the same time daily, often an hour after a meal. Use triggers like a hot drink. Privacy, proper positioning, unhurried environment. For older adults, focus on fiber, fluids, 1,500 milliliter min, safe toileting, reviewing meds, maybe abdominal massage.
And promoting regular exercise and maintaining skin integrity remain crucial.
Absolutely. Exercise stimulates peristalsis. And for skin, especially with diarrhea, incontinence, or ileostomies, clean gently. Use barrier creams, check frequently, change products promptly. Liquid stool is harsh on skin.
Okay, so we've assessed, diagnosed, planned, implemented, finally, evaluation. Did it work?
Right. How well did the patient meet those outcomes we set? And critically, from their perspective, are they having regular, pain-free movements? Can they manage their ostomy independently? Evaluation tells us if the plan worked or if we need to adjust.
Let's check back on Shavella's progress. How did Sergio evaluate her?
After a few weeks, her knee pain was down, controlled with acetaminophen, no more opioids, big win for constipation. Activity up walking 15–20 minutes, doing exercises. She was actively researching high-fiber foods, eating better, even using a whiteboard to track her fluids, bowels moving more regularly. That's successful, patient-centered care. The education stuck.
That's fantastic. What a journey through bowel elimination. It's so much more than a basic function, isn't it? From the deep physiology to the really nuanced nursing care, it profoundly impacts patient comfort, well-being.
It really does. And it brings up a key question for you listening. Thinking about Shavella's success, how will you take this holistic approach, the assessment, the education, the support, and apply it when you face new, perhaps even more complex patient challenges?
That's a great question to ponder. And speaking of challenges, imagine Shavella's niece, Lucia. She just learned her Crohn's disease has worsened, and now she needs an ileostomy. She's terrified, worried about her relationships, her social life. So what does this mean for Lucia? How would you, as her nurse, assess her immediate fears alongside her physical needs? How would you prioritize? What solutions could you offer for both the physical management and those deep emotional and social anxieties? And how would you know if your interventions actually made a difference for her?
This deep dive hopefully gives you the foundation, the knowledge, the skills, the empathy to approach situations like Lucia's with confidence, using evidence-based practice to provide truly patient-centered care.
You are now even more well-informed, ready to provide that exceptional care. Thank you so much for joining us on this deep dive. We really appreciate you being part of our learning community here. Keep learning, keep growing, and we'll catch you on the next deep dive.